Hello, my name is Vanessa Pick. I'm a family nurse practitioner student. Today I will be presenting a case involving a 79-year-old female diagnosed with CREST syndrome. This is a subtype of systemic sclerosis that primarily affects the skin, vasculature, and gastrointestinal system. This case highlights the importance of early recognition of autoimmune disease, a holistic and culturally sensitive approach to care, and the need for multidisciplinary collaboration in managing chronic illness. For subjective findings, the patient presented to the clinic with a chief complaint of increasingly difficulty swallowing and painful fingers when exposed to cold temperatures. She reported that her fingers turned white, then progressed to blue, and finally red as they warm, a classic sequence consistent with Raynaud's phenomenon. She also noted tightening and thickening of her skin on her hands, especially between her fingers, which made simple tasks difficult. Additionally, she experiences shortness of breath with exertion, chronic musculoskeletal pain, and recent unintentional weight loss, and has had recent unintentional weight loss. Her past medical history does include the diagnosis of Raynaud's 2 years ago. She also has hypertension and chronic pain that is managed under a long-term opioid pain management agreement. She has been on chronic opioid therapy for around 5 years and follows her contract requirements, including regular urine drug screenings with no signs of misuse or non-adherence. She denies depression or anxiety, but expresses frustration with the limitations caused by her illness. She lives in a shared home with non-relatives and has limited family support. For objective findings, on physical exam, she appeared mildly fatigued, but was alert, cooperative, and in no acute distress. Her fingers demonstrated sclerodactyly, and telangiectasias were visible on her cheeks and chest. These are both hallmark signs of limited cutaneous systemic sclerosis. Her skin was tight, particularly on her hands and face, and joint contractures were present in the fingers, limiting her range of motion. Lung auscultation revealed coarse breath sounds bilaterally, though she was not using accessory muscles, and oxygenation remained normal. Cardiac exam was also normal with regular rate and rhythm, and no murmurs or edema were present. For diagnostic workup, laboratory testing revealed positive anti-nuclear antibodies, or ANA, and positive anti-centromere antibodies, ACA, which are highly specific for CREST syndrome. A CT of the chest revealed mild interstitial lung disease, which can be an early sign of pulmonary involvement. This can be a serious and potentially life-threatening complication in systemic sclerosis. For assessment, the patient meets diagnostic criteria for CREST syndrome. The CREST is an acronym representing calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Her symptoms align with at least 4 of these components, supported by clinical findings and laboratory results. Other potential differentials included scleromyxedema. They were considered but ruled out based on her antibody profile, age, and clinical presentation. For plan of care, management was tailored to address her most pressing concerns while preventing long-term complications. These included Raynaud's phenomenon, nifedipine extended release 60 milligrams daily was ordered to help reduce vasospasms and improve blood flow. For the esophageal dysmotility and GERD, omeprazole 40 milligrams daily or twice daily was ordered to relieve reflux and reduce esophageal irritation. For the skin fibrosis, she was put on methotrexate 25 milligrams weekly to slow disease progression. For her chronic pain, just continued with the current opioid therapy treatment under her pain contract with consideration for the addition of non-opioid adjuncts. Further diagnostic workup, considerations, and discussion was made with the patient to obtain pulmonary function tests sooner rather than later, and an echocardiogram to monitor for cardiopulmonary complications. For referrals, rheumatology was put on board for disease-modifying treatment and long-term care. Also, consideration for gastroenterology if dysphagia and reflux symptoms worsen despite omeprazole treatment. Important patient education that was discussed. It was advised for the patient to avoid the cold if possible, or use gloves and hand warmers in the wintertime. The importance of medication adherence was stressed. Patient was advised to monitor for warning signs such as digital ulcers, increased dyspnea, or signs of renal involvement. And then smoking cessation, stress management, and light physical activity were also recommended. Follow-up plan for this patient, advised to follow primary care provider and rheumatology every 3 to 6 months. And then mainly to monitor for blood pressure and renal function to prevent sclerodermal renal crisis. Culture considerations for this case: using Geiger's transcultural assessment model, I considered how the patient's health literacy and time orientation could influence her care. She may be more present focused due to her situation, kind of living day to day, which can lead to non-adherence with routine follow-up, especially for asymptomatic conditions like interstitial lung disease. She's not, it's not really limiting her life at this time. I use the teach-back method, visual aids, and try to use clear, simple explanations to ensure her understanding of this condition. Ethical considerations. One major ethical issue discovered is the long-term use of the opioids. While the patient remains compliant, we as providers should balance non-malfeasance with beneficence. Her autonomy was respected by involving her in all treatment decisions. For healthcare disparities, due to her age, rural location, and socioeconomic status, the patient may face barriers to accessing medication, specialist care, and transportation. Insurance coverage can also limit access to treatment and diagnostics, which may delay care and affect outcomes. Team communication and collaboration. I used the SBAR framework to communicate with my clinical preceptor. The patient's complex needs were addressed through coordinated interdisciplinary care. In conclusion, this case demonstrates the importance of early detection and management of CREST syndrome while incorporating cultural competence, ethical awareness, and team-based care. Thank you for listening to this case presentation.